Okay, hello everyone. My name is Ranice Owens, and we are pleased that you all could join us this evening for this week's lecture and our second lecture of our 7-week KnowNeuroanatomy mini-series that brings you lectures from experts in the field covering different neuroanatomy topics each week. And this series was created by trainees and early career neuropsychologists to provide free, high-quality didactic opportunities. And at this time, we want to thank and recognize our KnowNeuroanatomy planning group for their hard work for Volume 2 of this mini-series. We also would like to thank our sponsors for their financial support for the series. And so before we start, we want to make everyone aware of our YouTube channel. Every Know Neuropsychology and Know Neuroanatomy lecture is available for your viewing pleasure. So be sure to go check it out, subscribe, and like our lectures. And here's some disclaimers for the series. This training is not meant to replace formal education in neuropsychology, and the views of the speakers are their own. Questions can be submitted via the Q&A box on the lower left of your screen, and a recording of today's lecture will be provided on our website and YouTube channel later this week. Now it is my pleasure to introduce Dr. Kristin Crocfer for today's lecture titled The Brainstem. Dr. Crocfer is a pediatric neuropsychologist at Phoenix Children's Hospital, an adjunct faculty at Arizona State University, where she teaches biobases of behavior and introduction to neuropsychology. She also holds academic appointments at Barrow Neurological Institute and University of Arizona College of Medicine in Phoenix. She completed her internship training at Kennedy Krieger Institute at Johns Hopkins and her fellowship training at Children's Health Children's Medical Center in Dallas. Her past and current research interests include the impact of mindfulness training on parents of children on the autism spectrum, the neuropsychological sequelae of demyelinating diseases, the neurocognitive impact of oncology treatment, and more recently, cognitive function in children with retinoblastoma. She also was interested in the systematic evaluation of training programs and student experiences. So now it's my honor to introduce to you all Dr. Crocfer, who will be presenting on the Brainstem this evening. You may now share your slides. I'm going to stop sharing so you can share your slides.
Thank you so much. And thank you everybody who's joining me. I know that it is a bit late where some of you are at. All right, does that look okay, everybody?
Looks perfect.
Perfect. All right. So when people think about the brain, everyone pretty much automatically thinks about the big squishy looking part or the cerebrum. Those slightly more sophisticated will also think about the cerebellum, which is that cauliflower looking structure in the back of the brain. But very few, when asked to describe or draw the brain, include the brainstem. And like my nephew, for example, let's give you a picture here. So for him, the brain looks like this. Because nothing comes without blood for a 10-year-old boy, this is his rendering of a brain. So the brainstem is often overlooked, but of course is essential for life. However, it's quite the complex structure, so I'm going to try to unpack it in a little bit at a time, including neuroanatomy, cranial nerves, and overall function. So at its most base description, the brainstem connects the brain to the spinal cord. That's kind of, the general understanding. As such, when we are discussing neuroanatomy, there are orientation terms in which I'm sure you've been exposed to, or if you're not yet familiar with, such as superior or above, inferior or below, rostral, which is in front of or anterior, caudal, which is behind or posterior, etc. 10-year-old boy drawing of the brain, because they don't know. All right, so I think I was discussing orientation. And so, when we're thinking about the brainstem, the big difference is that from the brain to the brainstem, there's a 90-degree shift. So what was ventral dorsal, which means towards the front or the back in the spinal cord and the brainstem is synonymous with inferior or superior in the brain. So I'm not going to go into great detail about orientation, but I think it's just good to know as neuroanatomy students and neuroanatomy people to know that there is that 90-degree shift when we're talking about the spinal cord. All right. So I'm sure you guys have hit this at some point, but I wanted to briefly review development of the brain and the brainstem. So just a quick review. So the nervous system develops from embryonic tissues called the ectoderm. Primary neurulation is the process that forms the central nervous system. And this is the process of the neural tube formation that forms into the spinal cord in the brain. So the development of the nervous system begins during approximately the 3rd week of gestation with the ectoderm, when it begins to thicken to form the neural plate. And that's the top picture that you guys see in the presentation there. So the neural plate then forms the neural folds and the neural groove. And then the neural folds and the neural groove eventually connect to form the neural tube. And that neural tube is what forms our central nervous system. So as you can see from this picture that the brain forms and / matures kind of from the front to the back, in that the brainstem and spinal cord are formed, more formed as the rest of the brain is continuing to still develop. And we know that brain development lasts for years and years and years, especially among men. Sorry for any guys out there. All right, so this next slide holds a lot of fun things to come, but for now, the rostral or front part of the neural tube goes on to develop into the brain, and the rest of the neural tube develops into the spinal cord. So the neural crest cells then become the peripheral nervous system, while the rest is the central. At the front end of the neural tube, 3 major brain areas are formed. So the proencephalon, or the forebrain, the mesencephalon, also known as the midbrain, and the rhombencephalon, or the hindbrain. So by the 7th week of development, these 3 areas divide further, and we end up with the telencephalon, the diencephalon, the mesencephalon, the metencephalon, and the myelencephalon. So the brainstem is comprised of the mesencephalon, the metencephalon, and the myelencephalon. And it's located just under the cerebrum. Again, that's that largest part of the brain that most people would recognize as a brain, and in front of the cerebellum, which is responsible for balance, among many other things. But of course, all 3 work together. And so the brainstem is just that stalk-like system that connects the brain to the spinal cord and is made up of 3 parts. So the midbrain, the pons, and the medulla, or the medulla oblongata, which is just more fun to say. So this picture is just to predominantly assist with some orientation. So you can see kind of the thalamus up top, and it sits above the midbrain. The pons are below the midbrain, and then the medulla is the bottom piece of it. All right, so here's where things start to get a bit more technical. Just as we go along, please don't get discouraged if it's difficult to keep up or if you're running into new terminology. This is completely normal, and while a working knowledge of this is important, I certainly don't deal with the brainstem at this level on the daily. So, just hang in with us and just kind of take in what you can. So the ventricular system, of course, goes through the brainstem. So a little orientation here. The 3rd ventricle is at the level of the diencephalon, and the thalamus is located on either side. So if you remember back to the last picture where the thalamus was at, you kind of get an idea of where we're starting in the brain. The diencephalon is connected to the 4th ventricle via the cerebral aqueduct, which courses vertically, and it connects the 3rd and the 4th ventricles together. This crosses through the midbrain, which we're going to talk about extensively, and opens into the 4th ventricle, which spans the pons and the rostral, or that frontal medulla area. The 4th ventricle then closes off to form the central canal and the caudal medulla, or the back area of the medulla. Again, we've got that shift because we're talking more spinal cord. So blockages in the cerebral aqueduct, in like embryonic terms, they call it the mesencephalic aqueduct, or you might have heard it be called the aqueduct of Sylvius. Those result in non-communicating hydrocephalus, as the cerebral spinal fluid can no longer get from one ventricle to the other. but we don't like blockages. So continuing kind of into the midbrain or the mesencephalon, there's pieces of it that you need to know that it's called comprised of the tectum and the tegmentum. So the area posterior, so to the posterior of the ventricle system at the midbrain is called the tectum. And you can see it in, I don't know if my pointer works, but you can see it in that first picture there. It's kind of a little arrow to it. The tectum is responsible for audio visual reflexes. So like when somebody slams the door and you jump all of a sudden, that's your lovely tectum kicking in. There are also two important parts of the tectum. So the superior colliculi, which is the top part, this controls visual reflexes, and then the inferior colliculi, so the bottom part, which controls those auditory reflexes. The tectum also includes the superior and inferior medullary velum, which closes off the fourth ventricle. So of course we need to stop that flow. So that's where that does that. Anterior to the ventricular system, making up the core of the brainstem, is the tegmentum. So that's going to be your second picture here, is kind of a side shot of it. This is the area between the cerebral aqueduct and the cerebral peduncles. So peduncles is Latin for foot, or in neuroanatomy terminology, it just means the bundle of nerves connecting different parts of the brain. So cerebral peduncles include the cortical spinal tract, among many other things, and that relays long motor tracts to contralateral side of the body. So as we look at this slice in the midbrain, we can definitely see that within the tegmentum, there's the red nucleus. So those are those red pieces. It's given this name due to the pink color, which comes from iron and hemoglobin and ferrin. And when you're actually doing, if you're able to see like a brain cutting, you can actually see this pigmentation there. And then the red nucleus, it assists with motor coordination, and it's part of the extrapyramidal system. This is kind of a shot at the midbrain here. So the midbrain also has branches that go into the basal ganglia, which helps with initiating and making smooth movements. So it contains substantia nigra, which is this black piece that you see here. It's named as such due to the color of the neuromelon. And substantia nigra contains the neurotransmitter dopamine, thus making it part of the dopaminergic system. And of course, this is related to movement via the basal ganglia, and also play a role in reward, addiction, and other behaviors. So I'm sure it's probably not the first time you've heard of that. Death of these dopaminergic neurons result in poor initiation of movement and resting tremor, which is, also known as, Parkinson's disease. So for those of you who ever want to study for your boards, this is something to tuck away right now. Substantia nigra, Parkinson's disease, all that fun stuff, dopaminergic pieces. Tuck that away. It will come up. All right. You can also see the cerebral aqueduct, which connects to the third and fourth ventricles. And then the final piece of this picture is the periaqueductal gray, which is gray matter that modulates pain, the sympathetic nervous system responses, as well as learning action of defensive and aversive behaviors. So this little piece of our brainstem plays a huge role in kind of our daily functioning in those regards. These are busy pictures. Don't spend too much time staring at them, but I just wanted to kind of highlight that first picture. So this is the spinothalamic tract, which relays pain and temperature from contralateral sides of the body to the thalamus. And then the second picture is the dorsal column medial lemniscus, the DCML. It's the tract that relays vibration and proprioception, or your body's ability to sense movement, action, and location from the contralateral side of your body to the thalamus. Another thing just to kind of note that I don't have a picture of is the choroid plexus. So this produces cerebral spinal fluid, and although found in all ventricles, we can see them in the third and fourth ventricles most easily, should you be, again, looking at a brain slice or brain cutting. Okay. So this is a really busy slide, but to continue understanding functioning of the brainstem, we also get to visit the cranial nerves. So there are 12 pairs of cranial nerves. And while we won't hit all 12 directly in the brainstem, we're going to come pretty close. So the ones that enter are sensory or afferent. And these allow us to take in information from our world. And the ones that are leaving are motor or efferent, which allows us to respond to our world. So we're going to go through the cranial nerves and the brainstem as they're associated with function. So again, starting with the midbrain, so we're up here, kind of near the top area of the picture. The midbrain is also known as the mesencephalon, or just kind of that middle brain. It's really tucked in there. You can't really see it from the outside, but it's the most rostral part of the brainstem. And cranial nerves 3 and 4 emerge from this area. And if you squint, you can kind of see them near the top of the figure on your screen. I know it's probably pretty hard to see from where we're at. So cranial nerve 3 is ocular motor and cranial nerve 4 is trochlear. So both are responsible for motor movement of the eye, and they are involved in 2 important reflexes. So the first one is the accommodation reflex. So this is when you can see and can focus on an object. So if you ever wake up early in the morning and your eyes are all blurry, you can't really focus on anything, that could be that playing a role as you wake up. And for this one, the optic nerve is your sensory input, so your afferent input. And then the ocular motor nerve is the motor nerve output, so the efferent output. The second reflex here is the pupillary light reflex. So this is just when our pupils constrict to light. So the optic nerve is the sensory input and the ocular motor nerve is again that output. All right, we're going to spend some time staring at this not busy slide. Again, I didn't want to give too many visuals that would make it just even more convoluted and confusing. So hoping everybody can just kind of tune in, listen, take what we can get from it. So the next area is the pons. So that's that pinkish area in the middle of the brainstem on your screen there. The pons are caudal to the midbrain, so below because we're in the brainstem area, and rostral above the medulla, so also anterior or ventral to the cerebellum. So the pons are identified as a bulge on the anterior surface and contain the descending motor tracts and relay nuclei related to the cerebellum. So thinking about, these tracts, you've got to think about all these neurons and all these pathways. If I could open that up, there'd be, hundreds of little strands looking things to kind of mimic your motor pathways. So try to imagine that. It's hard to capture in pictures. So the pons also contain part of the cortical spinal tract, which again relays long motor tracts to the contralateral side of the body. The middle cerebral peduncle, which contains fibers that arise from the contralateral pontine nuclei and of course to the cerebellum. It contains part of the spinothalamic tract, which relays pain and temperature from contralateral sides of the body to the thalamus. And then it contains the dorsal column medial lemniscus tract, again, that DCML, which again relays vibration and proprioception from contralateral sides of the body to the thalamus. Noticing a trend here, guys? We'll talk about that area where things cross over in just a minute. So the pons contain cranial nerve number 5, which is the trigeminal nerve. And this is a sensory reception. So sensory reception from the face, including mastication or chewing, pain and temperature. So if you think about the act of chewing, it's both sensory and it's a motor response. So it's both. There are 3 associated reflexes with the pons, including the jaw jerk reflex, or opening your mouth, putting something in there and kind of closing it back down. This is the trigeminal nerve, both input and output. The second reflex that is controlled here is the corneal blink reflex. So this is if you were to touch the cornea of one eye and both eyes end up blinking, you don't end up just blinking that one eye, both kind of reflexively react to that. That's that trigeminal nerve. So it's trigeminal nerve going in, but the output is the facial nerve or cranial nerve 7 coming out of there. The third reflex in this area for the cranial nerves is the tensor tympani and stupidus reflex. So this is when it just kind of contracts after hearing a loud sound. So it's your body's way to attempt to protect the cochlea or the eardrum from further damage. And so again, it just automatically constricts to a loud noise, and it kind of dampens sound for a short period of time afterwards in order to reduce the potential of ear damage. So this is the vestibular nerve in and the trigeminal nerve out. So the pons are involved in motor control and sensory analysis. They act as a sensory motor relay center. Kind of thinking about between the pons and the medulla. So there is 3 important cranial nerves which emerge from the pontomedullary junction. So that's that pons medulla area. And these 3 cranial nerves are the abducens, which is cranial nerve 6, and that plays a role in motor movement. Cranial nerve 7, which is facial sensory and motor input and outputs. So these are your facial expressions, salivary responses, tastes, etc. And then cranial nerve 8, which is the vestibular cochlear, which is talking about hearing and balance. So it's related to those pieces of things. All right. So the medulla, that purple little piece at the bottom of the picture there. So again, fun to say the medulla oblongata. It's much more fun to say. It's the most caudal part of the brainstem, and it sits between the pons and the spinal cord. So it contains the cortical spinal tract as well as the spinal medullary junction, which we just discussed. And then this is an important area because this is where the upper motor neurons descend through or cross or desiccate is kind of the terminology used. So they desiccate to the contralateral side. So these nerves can be sensory neurons going up or motor neurons going down. The spinothalamic tract and dorsal column, just going to call it DCML, also run through here. So again, it's quite the busy center. And again, you know, it's your relay station into the brain. So it makes sense that this is a busy area connecting your brain to your body. As previously mentioned, the medulla also contains the 4th ventricle and contains the reticular formation, which we're going to discuss here in some detail. All right, so deep in the brainstem, the reticular formation houses important nuclei or neurons that play a really important role, and it basically forms the central core of the brainstem. So some nuclei sit in the midbrain, some in the pons, and some in the medulla. So the reticular formation mediates level of consciousness is kind of one of the primary things that it does. It does many other things, but when we're thinking from a neuropsych perspective, you know, thinking sleep-wake cycles, you're thinking circadian rhythm, and damage to this area leads to lack of consciousness, differing levels of consciousness, including coma. So it's a pretty important part of our brainstem area. The reticular formation is comprised of 2 columns of neuronal nuclei. So these go up through the medulla and into the mesencephalon. The reticular formation plays a role in arousal and regulates, again, your sleep-wake cycle. It's also associated with habituation. So for example, when you're able to tune out background noise, that's kind of kicking in. It's responsible for somatic motor control. So tone, balance, posture, cardiovascular regulation, pain modulation, and respiration. So all these things are associated with respiratory and cardiovascular basic functionings, which is why the brainstem is kind of the make it or break it. You know, significant damage can very easily cause death. So kind of going back through, so we're in that medulla area. The cranial nerves in the medulla include cranial nerve number 9, which is the glossopharyngeal, and that's responsible again for sensory and motor reflexes such as gag reflex, throat sensation, including vomiting and movement. It also has taste as one of its things. It's one of the back parts of your tongue. I can't remember if it's the back 3rd or back 4th specifically, but it's one of those things. The second cranial nerve in the medulla is the vagus nerve. So this is cranial nerve number 10. This is a motor nerve responsible for parasympathetic innervation to the heart and lungs and other organs, including the muscles related to speaking and swallowing. The third cranial nerve in the medulla is cranial nerve number 12, which is the hypoglossal. And this is, again, another motor nerve responsible for the muscles of the tongue. So swallowing, gag reflexes, they're both sensory and motor in both glossopharyngeal as well as vagus nerve input and output. This is also true for the sneeze and cough reflexes. It's the same glossopharyngeal and vagus nerve. So kind of thinking about that junction. So some motor neurons come down, they cross at the medulla. Again, they desiccate is the term for it. And then the medulla is a critical region where both motor and sensory pathways converge, and it's home to essential cranial nerve nuclei and the breathing center. So again, without this, it's a big problem. So it's a relay station. It helps us kind of do all those automatic functions. So breathing, digestion, heart rate, swallowing, sneezing. And again, it conducts that pathway for nerve tracks. So only 2 of the 12 cranial nerves are not kind of directly involved in brainstem activity. I think it's number 1, which is up a little bit further in the brain. And then I think it's number 12, I believe, is not in here as well. So taken as a whole, we cannot survive without the brainstem. It's been termed kind of the old brain. I think it's just more of the, base brain, like you really can't survive without it. And I went through this way fast, guys. I can't believe I'm pretty much done. So again, a general working understanding of brainstem functioning is really important in neuropsychology. And I think it would take, ongoing review. You could spend an hour on, just going through a couple of these little areas. And I apologize for going so incredibly fast. While we don't know all of the functions completely, we do know that we have to protect this area, and damage to this area can cause death. We're just kind of scratching the surface of our understanding. Gosh, guys, I went through that so fast. Does your brain feel like this now? And, we're going to open it up to questions. Again, I apologize. I went through that really quickly.
Thank you so much. This was very interesting, and this was very informative of learning so much about the brainstem. I do have some questions, kind of just to get this started. I'd love to hear a little bit of maybe just some clinical cases, or if you have any experience, or just some different patients where you've had patients come in and you've done some neuropsych testing and worked with some of those patients that have had maybe damage to the brainstem, or maybe tumors within that area. And if you could tell us a little bit about that.
Yeah, so, thinking about the brainstem, I see a lot of peds. I'm a peds person. So, the tumors that we see are a little higher up in the brain typically. I think when we see brainstem stuff, I think we see it kind of more acutely with TBI. We have more issues with consciousness and arousal following a traumatic brain injury, which I see a little bit less of in the daily clinical practice. We do have an inpatient person who does see that and work with that regularly. From the outpatient perspective, it's rare that we don't actually see, if they're not fully conscious, we don't see them, but there are, it's a very interesting neuropsych path to work with somebody who's at an altered level of consciousness. We do have tests, and it's going to escape me right now, that you're seriously just looking for responses. So, you're saying their name, you're seeing if they even orient to you, you're, ringing a bell behind their ear to see if they orient to that. You're rubbing things on their hands to see if they can feel it or if they respond to anything. So I think neuropsych testing at different levels of consciousness is very different. Again, versus a child who's coming in for an outpatient eval who's fully with it. We get more behavioral stuff than these other guys. But I think it's a fun field, and there's definitely opportunity and need for people working in that.
Yeah, absolutely. I can imagine the inpatient floor when you have kids coming in. I'm a peds person as well too, so I'm in great company. But just in general, those traumatic brain injuries that you were speaking of as well, in what way have you seen, or just research, in what way, we have a question, does the traumatic brain injury impact the brain stem via maybe an accident, or that injury that has happened for that person? How does that then impact the brainstem?
Absolutely. So what comes to mind kind of off the top of the head is kind of a compression issue, right? We never want to have a compression. We never want to have anything that is going to block cerebral spinal fluid. We get hydrocephalus issues from those types of things. You think about where the brain stem is in your body, and everybody's always worried about like impact issues. It takes a pretty specific type of hit or injury insults to get at the brainstem directly. You'll see it a lot more in motor vehicle accidents, or more so even like motor versus pedestrian or motor versus a bicycle. Those types of injuries, the brainstem is pretty protected in a lot of ways, but again, very vulnerable at the same point in time.
Yeah, because I know you mentioned that it is very vulnerable because we need the brainstem to survive. So for those instances where it does get impacted, what is the typical trajectory of recovery kind of look like?
So that is very, very variable. So in my training, I did some time in inpatient, and, there were kids who, their eyes were open, and, they were just not responsive. And so for some of those kids, over the course of a few days, course of a few hours, course of a few weeks, some of those kids would come back to us. And then there are other kids that the injury is just so severe that that's kind of the state that they end up in. I'd say that's less common. I think recovery does happen. Recovery is very, very variable, depending on mechanism of injury, severity of injury. Recovery varies. So I couldn't say, 100% anything, but, for any sort of brain injury, the common kind of go-to is you expect to see the most recovery over the course of a year. Many people or kids, again, from my perspective of working with kids, they recover much quicker, but they still have those more subtle deficits that you don't necessarily see. And that's when neuropsych testing can really come into play and really help with that. Because how do you see executive functioning, issues in a 12-year-old? They're disorganized, they're messy. Okay, so are a lot of 12-year-olds. So I think that's why we do what we do, to kind of find those little nuances.
Yeah. Okay, so we have another question about neuropsych testing. So in the setting of that injury to the brainstem, what does neuropsych testing look like, for one? I can imagine it may look a little bit different in a setting. And what neuropsych testing kind of looks like with someone who's had that injury to the brainstem, and then what type of testing would you do testing over a recovery course to see a longitudinal outlook on recovery?
Right. Yeah, so a true brainstem injury, we're most likely not doing any testing outside of just that orientation piece. And again, the name, there's specific names. I haven't done it in years, so the names of those testing it's beyond me. It's escaping me, not beyond me. So neuropsych testing in that regard is literally more of an orientation. Is it, are they responding to stimuli, touch, et cetera, et cetera. A true brainstem injury is going to look pretty severe. Again, depending on level of consciousness and recovery there.
Yeah.
So it's very, very limited. Once we have regained consciousness, and once, we have healed to the point that we can actually engage, we start to do more neuropsych testing, but tends to be fairly limited. With increasing tests over time and recovery, we start to look at more pieces of it.
Okay. So you would typically, I'm assuming, pretty much like 1 to 2 years after you've reached that, being able to do an initial full battery.
Even it depends on that course of recovery, right? So we've done full batteries, 3-6 months out for somebody who's doing well, versus that year mark. If we're still having a lot of issues, we do that year mark to kind of get a new baseline.
Yeah. Okay. What type of treatment? So, with neuropsych and with patients that have these injuries, that then may impact the brainstem, what type of treatments, aside from neuropsych testing, but just that interdisciplinary setting, what type of treatments does that look like for them to regain some of that functioning?
Yeah. So again, I think it depends on mechanism and type of injury, severity of injury, but we do have rehabilitation programs. So that usually is kind of an all-encompassing physical therapy, occupational therapy, speech therapy. And a lot of speech therapy also kind of, depending on who's working, who's trained, can also do some cog rehab stuff. So again, it really is variable. But somebody who was severely impacted, who was able to, if they were able to walk away from a brainstem injury, would most likely engage in some sort of rehabilitation services. And through that, speech, physical, occupational therapies, and beyond that, obviously supports for school, those pieces that would be put into place as well as needed.
Yeah, but an injury to the brainstem is very, very
serious. It's
very
serious.
So.
I mean, you've got to think about what the brainstem does. I mean, if it impacts your heart and your breathing, well, is it so? It's just it's serious. You don't.
Yeah, controls pretty much everything. That impact. Okay. All right. And then you talked a little bit about the medulloblastoma. So is there a typical type of neuropsych profile for a child with medulloblastoma?
Yeah, so I mean, I think the profile, what we're looking at is we don't often get what we call a baseline. So we don't often get baseline testing for kids pre-tumor or cancer or whatever. We get them after the fact. So what we are looking for at that point in time is not just impact of tumor or cancer, but we're also looking at impact of treatment. So we know that certain chemotherapy agents directly impact fine motor skills. So part of our testing always includes that. Depending on what kind of treatment they received, what kind of chemo they received, we're looking at other types of issues. So attention, executive functioning, processing speed, working memory, a lot of those are more prone to show up as marginally to more moderately problematic following certain treatments. So we're always testing those things because we know that that's kind of what we would typically see, but some kids can go through all of it and walk away with a completely normal profile versus others get hit really hard. It's pretty variable.
Yeah. Does it ever tend to press on the brainstem? Have you ever seen that?
Absolutely.
Okay.
Yep.
So what does that outlook look like for?
So compression, it depends. So there's something called a Chiari malformation, which is a compression. And a lot of people, it doesn't really impact a lot of things. People will walk around with Chiaris and not know that there's an issue at all. Versus others will have kind of more motor coordination, balance issues, and it starts to impact some of that functioning. So there's definitely, there's definitely that piece of it, and that they do decompression surgery on those types of issues all the time. Other sort of compression injuries, again, recovery is variable, depends on mechanism severity.
Yeah, all the different factors that go into it. Yeah. So then I have another question. Just some resources, some really helpful resources. We know that you're also a professor. And what resources would you give to the trainees on Zoom today and who are going to watch this recording later that would really be helpful for learning and picking up those skills of neuroanatomy?
Oh, that's a great question. So neuroanatomy is one of those things that you either get it in school or you don't. And so I think a lot of times we are, as students, and I wasn't in your guys' shoes too long ago there, that you take on your own supplemental. So I know I did the KnowNeuroanatomy class personally. I took, other avenues just because my program wasn't necessarily neuro focused. I don't know. I think books are difficult. I personally really benefited from one of those coloring neuroanatomy books because for me, it was a coping skill and I got to learn certain pieces of things as I was going through training, and it was not mindless, but mindless. It was kind of enjoyable. So I personally did that. I love your guys' series. I think that's going to be a great resource for everybody moving forward. I'm trying to think of off the top of my head what else I can come up with, but I'm not 100% sure. I do know that I'm referring more and more of my students to like the board review books for like broad, like encompassing, like you're looking at this thing, here's the brain pieces involved, boom, 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 it's right there, pretty clearly stated. I've been referring a lot of my students to the board neuropsych planning book as well.
That's helpful. That's helpful. Well, thank you. I think a lot of trainees, some have the really intense neuro focus in their programs and some trainees don't. And so it's really helpful to be able to have those resources to be able to fill in some of those gaps because neuroanatomy can be one of those subjects that can be a little difficult to grasp and hold on to.
Yes, yes. And just, a note on that is that neuroanatomy is important, but it's more functionality. And in training, you're going to get all sorts of different types of training experiences. Some supervisors are going to be all about neuroanatomy. Some are going to be like, well, what's functionality? What do you really need to know? Yeah. So you also are at the mercy of whoever you're training under, how much exposure you get to that as well. So every new case, if you're into the neuro piece of things, every new case, you should be researching on your own. What's the impact? What am I looking for? What am I looking at? The research never ends.
Of course. So then what is your take? Do you enjoy the more functional aspect of neuroanatomy? Do you think that's the more important aspect when it comes to the neuropsych world and testing and how you then interpret your patient's results? Or
so I'm 100% what's important in the moment, what's important for the family to understand. The doctors, the teams already know from a physiological piece, like what's happening. So for me, it's functionality, 100%. I think again, neuroanatomy is important, but in studying for boards myself, it's functional neuroanatomy. It's not the nitty gritty, itty bitty little details about this or that pathway. That's not on there, guys. So again, get the broad exposure, but tailor it to your setting and your population, because not everybody needs that same level of detail.
Absolutely. And I think you raise a really good point too about when you do the feedback with, in the pediatric population, feedback is mainly with parents and, the kid, if they're maybe a teenager and, want to understand everything a little bit more. And with adults too, it's really understanding when you provide all this information to them, what's most important. And so they may already receive everything from neurology, but they really want to know how this is impacting their functioning.
Exactly. By the time they get to us, they don't have a ton of questions about that. They want to know what's next. How do I help my kid? But again, different settings.
Yeah. And as trainees, that's something we kind of just have to roll with.
Yes.
But it's all important. It's all important. Okay. And so we have different people in the Q&A giving you some shout outs and saying that you're amazing and they enjoyed your presentation. And this has been a really good resource for our trainees and for our professionals as well on here. So we thank you so much for just spending your time with us this afternoon / this evening, wherever everyone is located right now because of the time zone differences. And so we thank you so much for taking this time out to give us a lecture in our KnowNeuroanatomy series. So thank you so much.
Awesome. Thank you so much. Have a great day, guys.
All right. Have a great day.